We are delighted to have one of the UK's most experienced consultant paediatric ear, nose and throat surgeons here today, courtesy of my brother-in-law, Shay's uncle. Mira de Kruijf has come and given her time to speak to you all here today, so I'm sure we'll get a huge amount out of this. After Dr. Mira's presentation, we'll have a very short break before Anne comes on. During that short break, you can grab a drink, go down, see your kids, give them a drink if they need it. But until then, Dr. Mira de Kruijf, please.
I'll shout. Good morning, everyone. Thank you for the opportunity to speak to you today. So I was asked to speak about the kind of interface between GAND and ENT. And actually, when I was first asked to do it, I really struggled with what to speak to you about, because actually the number of children who have GAND are really, really small. And so we don't really have the evidence base that we would have for other syndromes about what really to speak to you about. So I'm a paediatric ENT consultant, I'm a surgeon, and we have a sort of international WhatsApp group. And so I asked that WhatsApp group whether any of them had any experience with children with GAND, and the answer was no. And then I really panicked, because I thought, God, what am I?
Here we go.
Oh.
It's done.
I won't be singing, you're lucky. And so then I really panicked, about what to speak to you about, because that international group kind of spans from Argentina to Australia. And then I thought, maybe if I just draw back, because at the end of the day, GAND is a neurodevelopmental disorder. And neurodevelopmental disorders are something that we know quite a lot about. And in the Children's Hospital, I look after, from an ENT perspective, about 90% of the children with neurodevelopmental disorders. And there is quite a lot of overlap. So neurodevelopmental disorders, they account for between 2 and 5% of children. And it's a group of sort of acquired, a group of sort of acquired or congenital disorders that are associated with dysregulation of the brain or the nerves and the muscles. And the functional effect of that is that there's some types of impairment. And so what I did was I looked at the literature that existed within medicine for GAND to see what were the areas within ENT that I could speak to you about. And these are kind of the seminal papers, and this is actually Tyler's paper here, which had the biggest case series of about 52 children. And these are the themes that I identified based on those papers and more. So the first of these were neonatal feeding difficulties, so feeding difficulties in really early childhood and later on. Childhood hypotonia, so kind of floppiness and low tone. Reflux, drooling, sleep disorder, and apraxia. Does that seem to kind of ring through like a few? Because otherwise this talk would have been entirely useless to you. And what I've done is I've kind of gone through each of these individually within the talk. So if we start with neonatal feeding difficulty, this is one of those papers, and I've highlighted here this kind of small recessed jaw. And I'm not sure whether when your babies were born that is something that you would have noticed or perhaps not. But the reason why it's important, and you can see about a quarter of children, so not a small amount of children, about a quarter of children were found to have that small recessed jaw. And the reason why it's important is, from a medical perspective, we use these terms retrognathia and micrognathia. Retrognathia is where you have, so both of them refer to the lower jaw. And a retrognathia is where the lower jaw is a normal size, but it's set back. It's that recessed jaw that they were talking about. Micrognathia is where the jaw is smaller than it should be. And in children, they can have either retrognathia or micrognathia, or both. They can have a retromicrognathia. The reason why that's important is because the function of your lower jaw is to support your tongue. If you stick your tongue out, that's only half your tongue. The other half of your tongue is much further back, you can't see it. And the function of the lower jaw is to support that lower half of the tongue. If you've got a small jaw, or a jaw that's kind of posteriorly set back, that tongue isn't supported. And what that means is, for a baby to raise their tongue to the roof of their mouth to create a vacuum is really difficult. Really, really difficult. And that's whether the baby is on the breast or on the bottle. Because what a baby needs to do to feed either of those ways is to lift their tongue to the roof of the mouth, suck, create a vacuum, and that vacuum draws milk. So if 25% of children have that small recessed jaw, then actually it's not hugely surprising that those babies would have difficulty feeding. And simple feeding modifications can help. So for a breastfeeding mother, they say the ear, the shoulder, and the hip should be in a line when you're feeding your baby. But actually, if a baby has a recessed jaw, what you should be doing is kind of tilting your baby towards you, because when you tilt forward, the jaw comes forward, and that kind of helps relieve some of the pressure on the tongue. Same for a bottle feeding baby. So actually, really simple lifestyle modifications can help feed your baby if that's something that's happening. However, the other thing to say, and I'm not sure, because you are the guys with lived experience of this, is that you need to consider the impact on breathing. So I don't know if this, so the video that you're going to see is just the upper part of an airway. This bit here, I'm such a shorty, I can't reach, but that's the back half of your tongue. And if it's not supported, you will see what happens is that tongue sort of flops forward and covers the breathing tube, which is here. Yeah? So if a child has a posteriorly set jaw or a small jaw, not only can it affect their feeding, but it can affect their breathing. So if I play the video, you can just see the edge of a metal blade that I've got there. And as I pull the blade back, you'll see the tongue base fall forward. Or that's the idea, yeah. So you can see breathing, breathing in, breathing in, breathing in. And as I withdraw the blade, can you see that tongue base kind of collapsing forward to obstruct the airway? And that's another reason why children can have difficulty feeding when they've got a small recessed jaw, is it's not just that higher level where the tongue needs to rise and create a vacuum, it can also affect their breathing. And in babies, if their breathing is affected, the next thing that will follow is their feeding. Yeah? Usually that's accompanied by noisy breathing. So I'm not sure if your babies were noisy when they were born, but if they were noisy, that's probably what was happening. And actually that's quite an easy fix, surgically. So things to consider would be breast or bottle feeding support. Actually, even though there mightn't be a GAND feeding specialist, a cleft nurse would be able to give you a whole load of information about that. And cleft nurses are very numerous. I'm sure all your communities will have cleft nurses, because a lot of cleft babies have small jaws. So cleft nurses would be very well cited on how to kind of support you feeding your baby, be that breast or bottle or a combination of both. If your baby is noisy, they should have an assessment of their breathing. They should have overnight oximetry, which is just a little clip on your finger to check their oxygen levels, or polysomnography, and I'll speak to you about those later when we talk about sleep apnea. Morning capnography is basically when your baby wakes up, they check your baby's carbon dioxide levels. And the reason for that is because babies are so well engineered, they don't drop their oxygen levels until quite late. So if you're watching your oxygen levels, you're watching the wrong thing. What they do first when you're not coping with breathing is they raise their carbon dioxide levels because you're not ventilating efficiently. So if you're worried about a baby's breathing, it's not the oxygen, it's the carbon dioxide, which is that morning capnography. And if your baby has any of those difficulties, you can ask to be referred to either a paediatric ENT team or a maxillofacial team. So that was from a neonatal feeding perspective. From a hypotonia perspective, hypotonia is essentially the medical word for floppiness. And again, if you look at the literature for GAND, you can see that hypotonia present in 100% of children. So most of them being described as floppy, and you can see feeding issues and reflux were reported in 82%. So I'm not sure if that is something that would have been your reality, but based on the literature, that's what it is. And then the other thing that I read was persistent oromechanical issues, which is that sort of coordination and kind of chewing and swallowing and drooling. And so I've tried to tackle all of those. And actually, that if all of these things, the feeding, the reflux, the drooling, the secretion management, all of that ties into that central hypotonia. Feeding, if we talked about feeding, swallowing is really complex. I mean, you think swallowing is like a life 101, but it's really not. So in a past life, before I did Peds ENT, I was a head and neck cancer surgeon in adults. And if you had to send an adult for radiotherapy, they'd nearly always have a feeding tube, a PEG tube, for the radiotherapy for 6 weeks. And at the end of the 6 weeks, that adult nearly always forgot how to swallow. So, you think it should be a life 101, but it's really not. And in babies, if you don't push their oral feeding, you will find, I'm sure some of you will have lived experience, if you don't feed them orally, very quickly they lose the ability to do that, and they have to work doubly hard to get them to swallow again. So it's worth investing at the start and kind of giving you guys the understanding so that you can advocate for your kids going forward. So feeding, when you feed, the first thing you have to do is chew, and that's pretty complex. Your tongue then has to turn that food into what we call a bolus, a bowl. Your tongue then has to propel that bolus to the back of your mouth, and then your brain has to trigger once that bolus hits the back of your mouth for you to swallow. You cannot breathe and swallow at the same time. So you have to turn take between breathing and swallowing, and after you swallow, your esophagus has to move like this, from top to bottom in a series of coordinated movements. And so you can see in children who've got low tone or any form of neurodevelopmental problems why feeding would be an issue. And so sometimes children aspirate. Reflux then, so this is essentially a really it's an oversimplification of reflux, but you swallow, food moves down this way and it enters your stomach. Normally, there's a sphincter here, a band of muscle, like a ring of muscle called a sphincter, that prevents acid from moving from your stomach up into your esophagus, prevents reflux, basically. But it's muscle. So just like any other muscle that's affected by low tone, that muscle is affected by low tone. So they're more likely to reflux, yeah? And the symptoms of children who reflux are vomiting and sort of fussiness in infants, that sort of drawing up of legs after feed. So when you're breast or bottle feeding a baby, you don't reflux like this all the time. You reflux in what we call reflux events. So you get a spike and then it settles, and a spike and then it settles. And depending on where you are on the spectrum, you'll have X number of spikes. But what happens in babies is your food pipe and your windpipe, they live side by side, literally side by side. So when you have a reflux event, that acid spills over onto their windpipe, and what the windpipe does is it spasms shut to protect your lungs from that reflux, from that acid. But when that happens, it feels like, for the baby, like they're choking, like they can't breathe. And so they have a panic. And so I'm sure you will have, so my son had reflux. And what happens when you're feeding is, they suddenly pull off the breast or the bottle, and you're inconsolable crying, and you can't really suss out why that's happening. And that's probably what's happened. So they draw up their legs because of the pain. Bloating, burping, hiccups. The difficulty is, though, all children have this, whether they've got reflux or not. And it's more just an awareness, because you know your child, of where they sit on the spectrum of those symptoms, as to what we can do. So in terms of the diagnosis and investigations, the history and examination, so all of those features that we spoke about before, when you examine a child, there's often very little to see from a reflux perspective, because it's not happening on the outside, it's happening on the inside. A barium swallow is a test some of you might be familiar with. The difficulty with the barium swallow is your child has to be able to swallow in a coordinated fashion for that test to be of any use. This is quite a useful study, a 24-hour pH study, and you can see that little one has a pH probe. So it's like a little NG tube, like a little flexible tube that you pass down the nose into the stomach for 24 hours. This here is the recorder, and after 24 hours they download it, and they'll tell you whether your child refluxes, and if so, how badly. And that can decide then what sort of treatments are offered to your child. An upper GI endoscopy is where your child is given sedation, or usually an anaesthetic, a full anaesthetic, and we put a camera down their mouth to have a look at their stomach to make sure that there's nothing else that's causing the reflux. So in terms of what you can do with lifestyle changes, it's to hold your baby upright. It's like all babies. Hold your baby upright for about 30 minutes after a feed. Burp your baby regularly in between the feeds, so not just at the end of the feed, but pace your feed, so small volumes and often, and burp them regularly in between. You can raise the head of the bed 6 to 8 inches, so put a book maybe at the head of the bed, and avoid large meals 3 hours before bedtime. They're the kind of conservative things that you can do that I'm sure you're all already doing anyway. in terms of the medical treatment, you've got anti-reflux therapy. Some children need 1 medicine, some children need 4 or 5 medicines. It depends on the spectrum. A swallow assessment is really useful. And I'm a big advocate in keeping the child feeding orally if possible. Because what you don't want to do is to have your child NG fed or gastro fed when they've got some ability to enjoy food orally. So a swallow assessment will tell you what consistencies your child can safely have. Because it's fine if they need a nasogastric tube or a gastrostomy tube, but if they can have some food by mouth for pleasure, then we should do that. Surgery is reserved for the kind of end of the scale. So if your child cannot feed sufficiently orally to get their nutrition, we would put a gastrostomy tube in. Even with a gastrostomy tube, we would still advocate, if your child can, to have some feeds orally, because quality of life is really important. Fundoplication is where they sort of pin, they wrap this bit up here to kind of form a fake sphincter, if you will, minimize the risk of acid coming back up again. And then a tracheostomy and a laryngotracheal separation are things that I do, but it's been a long time, 23 years doing this job, and we've never had to do one for just reflux. Laryngomalacia is something I didn't see in the literature, but I wanted to mention it because I'd be surprised if children don't have it. So it's really common. It's so common, we nearly look at it as a variant of normal. But effectively what happens is when they're born, babies make a high-pitched squeaking noise when they're breathing. So, and I'm not sure if any of you would have noticed that, but it's that kind of noise. It's not a snore. It's a much finer sound than that, nearly always when they breathe in. And the reason for that is because, so that's what a normal airway looks like. That's what your and my airway looks like. And you can see it's open, and we breathe through that, yeah? Laryngomalacia is where, can you see, this is your epiglottis, and these are called your arytenoids, yeah? And there's a band of tissue that kind of joins the two. They're called your aryepiglottic folds. When that band goes all the way to the edge, can you see it pinches everything forward, yeah? And so what happens is when a child breathes in, it collapses like that, and airflow isn't smooth. It doesn't go in and out smoothly. It's turbulent. It has to go around and in between, and that turbulence causes noise. And that noise is that that you'll hear babies make. The treatment for it's really simple. It involves a general anesthetic, but it is really simple. And what you do is you cut these holes, and you can see immediately that opens up the airway. It looks really sore, but actually 24 hours in hospital and children nearly always go home. The caveat is what their swallowing is like, because if you've got neurodevelopmental disorders, sometimes your swallowing can get a little bit worse before it gets better, but nearly always they're better. There's a bit of a chicken and egg theory about reflux and laryngomalacia. So the kind of reflux theory is that the acid causes the tissue to swell, and that swollen tissue makes those bands thick and causes the laryngomalacia. The airway theory is that sort of blocked airway causes the negative pressure inside the chest that brings the acid up. To be fair, it's an academic conversation. It makes no difference. Functionally, the effect is the same. That's what children have. And they nearly always coexist. Drooling then. The thing to say about drooling is, if your child is drooling, they're not making more saliva than you and I. We make about 1.5 to 2 liters of saliva a day, all of us. The thing is, though, we're subconsciously swallowing that saliva all the time. You don't think about it, but 1.5 to 2 liters is a lot of saliva. But that's normal. That is normal. 70% of it comes from these glands here, just here, your submandibular glands. About 15% come from your parotid glands, so this gland here, and then you've got hundreds and hundreds of other saliva glands kind of embedded in the floor of your mouth and in your cheek. And actually saliva is good. You need saliva. So it protects your teeth and your gums, it's got antibodies in it, it lubricates the food, helps digest the food, and so it does a job. The difficulty with the drooling is not the saliva, it's that oromotor coordination we talked about. That means that they're not managing that saliva. They're not swallowing the saliva in the same way that they don't swallow their food. And so there's a very clear management ladder about how we manage these children in the children's hospital. There's nearly always an element of reflux. And if you have reflux, I'm sure you've had it, you know, food repeats itself. You get like a rush of saliva in your mouth. So we give them anti-reflux management, fluoroscopy to kind of modify your feeds, that's a swallow assessment, and then you manage the drooling. And there's 3 different options really. So you've got speech and language therapy, really difficult. Funding for community speech and language therapy is pretty much zero at the moment, and it's a real shame. And in the children's hospital, if we asked the speech and language team to review children as outpatients, the answer is no. And we're the largest tertiary children's hospital in Europe under one roof, the Royal Manchester Children's Hospital. So, it's a really sad state of affairs, but from a speech and language therapy perspective, the first line should be oromotor exercises. There are lots of videos on YouTube that you can have a look at, but in terms of actual speech and language therapy funding, for you might be lucky, you might live in an area that's commissioned for good speech and language therapists, but they're few and far between. Medical therapy will be things like hyoscine patches, I'm sure some of you will have had them, that you change every 72 hours. Some children can get a reaction to the hyoscine. And then the other medicine is glycopyrronium. The thing with those medicines is they're really effective if it's saliva. And there's a difference between saliva and secretions. Secretions are, I know it sounds like, saliva is really thin. It's drool, basically. It's this really thin stuff that you see. But sometimes, if you ever suction your child, it's not saliva, it's thicker secretions, and they're airway secretions. And the hyoscine and the glyco, they make them worse. So it's really important, if we're calling it drooling, that we're sure it's actually saliva and not airway secretions, because how you manage them are 2 completely different things. And then this is generally where I tend to get involved. Once the medical treatments don't work, we have botulinum A, which is Botox. Yeah. The way Botox works is you inject Botox into these glands here, so the 2 submandibular glands, and either one or both parotid glands. And what it does is it blocks the release of the chemical that releases saliva. But it's like all Botox, it's temporary, so it lasts between 6 and 9 months. And you need to keep topping it up. And depending on your child, that can be delivered under a local anaesthetic, like a cream, when they get a cannula, or a general anaesthetic. But you have to keep repeating it. The next one is duct clipping. So if I bring you back to that picture, so I said 70% of saliva is produced by these glands. This is the duct that produces it. So what you can do is make a little nick in the floor of the mouth and put like a little clip over the duct to block that gland from releasing saliva. Day case procedure, absorbable stitches, but involves general anaesthetic. And it will work if it's just saliva, not if it's saliva and secretions. But it is a very straightforward thing to do. From a surgical perspective, half an hour. And then the last one is submandibular gland excision. There is a small percentage of children where when you clip their ducts, it works for a while. And then, because children's bodies are amazing things, they find a way to bypass that saliva circuit and they start producing drool again. The next step then would be to excise, to remove that gland. And that's a bigger procedure. So that would involve making an incision here and just removing that whole gland. And if you remove the gland, there is a small theoretical risk that you can damage the nerve that moves the tongue and supplies taste to the tongue. So it's not a small procedure. And I say that to all my families because the difficulty is sometimes you just want your child to be better. And if it sounds like it's a one and done fix, it seems an attractive option, but it's not for nothing. Never happened to me in 23 years, but it's a theoretical possibility. And so that's drooling. Sleep disordered breathing is what we used to call sleep apnea. It's really common. There's lots of children who have sleep disorder. Taking out the tonsils and adenoids is nearly always the first line treatment. What happens with sleep apnea is this. I cannot reach, but it starts with sleep. So when a child falls asleep, when we all fall asleep, we go a bit floppy, don't we? Normally, what happens is our bodies can compensate for that floppiness, but in some children and some adults, they can't compensate for that. And so what happens is they have a collapse of the airway. And that causes an apnea, which is where they stop breathing, or a hypopnea, which is where they partially breathe. That then causes their oxygen levels to drop and their carbon dioxide levels to rise. The carbon dioxide is the key, because when the carbon dioxide levels rise, the carbon dioxide dissolves in the blood. It's detected by the chemoreceptors in our body, and it's fed back to the center that drives breathing in our brain to tell you, wake up. Why? Because when you wake up, your tone improves. So often what you'll find is your child will snore, their mouth breathe. It's this bit is that restless sleep that they talk about. So they'll half wake up, move in their bed, and fall asleep. And that's why as they're sleeping, they're moving all the time. If they've got sleep disorder, because that's exactly what's happening. Their brain is telling them, because you're not ventilating effectively, wake up, restore your tone, fall back to sleep. And that will happen to a greater or lesser extent, depending on where on this spectrum of sleep disturbance your child sits. So we don't offer any treatment for snoring, because 15% of the world snore. Don't care. The opposite end is an apnea. The definition of an apnea is where a child stops breathing for 10 seconds. And actually, thank God, most children, they don't live there. But they live in the grey, somewhere in between. Yeah? And depending on where they sit on that spectrum, we decide about what to do. And that is very much, as is all of the stuff that I've been speaking to you about, where joint decision-making comes into key. So you'll all have heard about, the truck driver who had sleep apnea, who fell asleep at the wheel. Children, when they're tired, they don't sleep. They go bonkers. They're really hyperactive, and then they just collapse. And that hyperactivity is something that children get. But there is an increasing recognition that anywhere between 7 and 70% of children who have other issues have elements of sleep disordered breathing. And the thing with those children is that it's not just the tonsils and nads, it's multi-levels. It's lots of levels within their airway. In that context then, they tend to present earlier in childhood with this sleep disordered breathing, probably related to that floppiness. That obstruction is often present not just at night, but sometimes also during the day. Taking out the tonsils and adenoids might help, but rarely cures. And I think that's a key to speak to people about in the kind of counselling period. The questionnaires that we use to kind of gauge whether a child has sleep disordered breathing don't really work well in children who have multi-level levels of airway obstruction. But this is the key. That low oxygen and sleep fragmentation, that kind of half waking, half sleeping, half waking, half sleeping, really affects the child. Traditionally, we've always spoken about cardiovascular complications, that really bad sleep apnea can affect your heart. It's really unusual for children to have that because they're so well engineered. This is the key. This is the key, their cognition and their behavior. It's really unusual for a child to have cardiovascular complications, but I think increasingly we're recognizing, any parent knows, right? You're sleep deprived, and you just don't function the way you would if you slept. And if you imagine your child doing that all night, every night, tough. And it's not learning, and I don't mean stupid things like math and science learning, I mean life learning. Waiting your turn, sharing your toys, feeling awake enough to feel involved in the playground. They're the things that matter if your child has sleep disturbance. And it's not the usual suspect, so you can see for dramatic purposes these massive tonsils, but it's rarely the case. It's these things. So that mid-facial hypoplasia, where the middle of your face is kind of underdeveloped compared to the upper and lower bits. The skull base morphology is different, which means that the veins and the blood supply drain differently. That retromicrognavia that we described at the very beginning of this talk. Nasopharyngeal stenosis, which is where this part of the nose is really narrow. Big tonsils and adenoids and altered neurology. This skull base morphology and altered neurology are the reason why there's a difference between peripheral and central causes, because I think Rebecca was saying some of you were asking about the difference between peripheral and central causes of sleep apnea. Oximetry is basically just this. It's a little sticky plaster that you stick around a child's finger or their toe, and you measure their oxygen levels overnight. You can do it in hospital, you can do it at home, but it doesn't distinguish between central and peripheral or obstructive cause. It won't tell you the difference. And actually, it's a really poor tool. It's a really poor tool. So it will capture about 53% of children with sleep disorder, but by the same token, it'll miss 47%. And sod's law is, on the night that your child has this, they'll have the best night's sleep they've ever had. Or the machine beeps so much, it's just measuring their oxygen levels when they're awake, because it's alarming all the time. So it's a pretty useless test. In the Children's Hospital in Manchester, we don't use it. We don't use it, because it's just counts, really. This is the gold standard. So when people talk about a sleep study, this is medically a sleep study. This is not. This is just overnight oximetry. This is a sleep study. And you can see the difference. Yeah? It measures all of these parameters. So EEG, it measures brain activity. It measures EOG, so eye activity, because your eye activity changes when you have REM sleep. EMG, so it measures muscle activity. The reason muscle activity is important is because if you've got sleep apnea because of big tonsils or adenoids or because your jaw is small, when your oxygen levels are low, your body will try and breathe, because nothing is wrong with the brain. Your body will try and breathe harder to compensate for that, and that will be picked up by the muscle probe. But if you've got a central problem, the problem is this. The problem is this not telling this to breathe effectively. And so your muscles won't do what they're supposed to do. And so if you see the oxygen levels fall and the muscle probe staying stagnant, then that tells you nearly certainly between the EMG and the EEG that the problem is more central rather than obstructive. Yeah? Why that's important is because it completely changes how we manage the child. Because if it's central, taking out the tonsils and adenoids is not going to do anything. Yeah? So this is the gold standard. The difficulty is accessing it. So in the Children's Hospital, we've got a lab that does it, but even then our waiting list is ages and ages and ages. But this is the gold standard. And if you look, if I go back to that paper, because all of this is based on that paper, you can see 35% of children with large ventricles, so the kind of spaces, the fluid-filled spaces in the head. So a third of children will have central causes of sleep disorder. Abnormal white matter, that corpus callosum that Tyler was talking about, a fifth of them will have abnormal white matter. So there's lots of reasons why they would have central causes of sleep apnea. That's not to say taking the tonsils and adenoids out is the wrong thing to do, but it's really important to counsel parents beforehand how much good an intervention can do, because then you have to go away and have a think about, knowing your child, whether it's something you think would be worth doing or not. Increasingly in the Children's Hospital, we do this for children with neurodisability. So any child, and then as I said, I look after about 90% of the children who have neurodevelopmental disorders. And I always do on those children what we call a DISE, which is where they're anaesthetized but asleep rather than deeply anaesthetized, and you measure, based on that camera, the different levels of their airway that are blocked. So this is just at the entrance of your nose. These are your turbinates, and you can see that's really blocked, so that's one level that needs to be managed. Those are the adenoids. When you get to the back of the nose, that's what the adenoids look like. That's the soft palate. So at the very back of your nose, where your soft palate is that collapsing? Tonsils and adenoids, obviously. This is the tongue base. So if you open your mouth and have a look at your tonsils and adenoids, this is exactly the same tissue, but it's pushing on the airway. Can you see? And then the last is that airway. So using that assessment, you can assess all of those different levels of the airway to see where the obstruction is. Yeah? These are the challenges that you have to kind of get artificial sleep, so we have to work with our anaesthetists to do that, so not all centres will offer this. There's a standardised grading system that we use. And clinical utility is, we're not still quite, because it's relatively new technology, who really needs a DISE. So a child who's otherwise well, who's got straightforward sleep disorder, doesn't need a DISE. They just need their tonsils and adenoids out and see. But for children who have neurodevelopmental disorders, I'm pretty convinced they do, because you nearly always find something else. And so this is what I do in the Children's Hospital. We take pictures of every level, so that adenoid, the soft palate, the lateral pharyngeal wall, which is essentially the tonsils, the tongue base, that upper part of the airway. And then what we do is at the end we grade each level. So 0 is kind of no obstruction, 1 is partial obstruction, and 2 is complete obstruction. So we take pictures of every level, and then that way at the end of the procedure we can come back and speak to the parents to say, for your child, because your child is a child who happens to have GAND, for your child, these are the levels of airway obstruction. We nearly always start with just the tonsils and adenoids, because perfection is the enemy of good, isn't it, we say in Ireland, and you just want to take your child to good enough, not perfection. So usually we take the tonsils and the adenoids out first, and then we see what kind of a child we have left, but we have the information about what other levels of airway obstruction there are that we can surgically reverse for you, because sometimes the answer is none. Sometimes the answer is, after the tonsils and adenoids, there isn't anything more surgically that we can do. But it's still useful information for you. So these are at the moment the children that we do DISE on in the Children's Hospital. So children who have persistent sleep disorder after the tonsils and adenoids are out, before adenotonsillectomy in high-risk patients, so any child with neurodevelopmental disorder, where there's a significant history of sleep apnea, but the tonsils and adenoids are really small because it's nearly always another level that's the problem. And then the other two are not applicable to this talk. So in terms of the treatment options, you've got wafting oxygen, which is just kind of oxygen placed by the side of your bed. CPAP, which is this. CPAP really poor. Are any of your children on CPAP? No. There's not a snowball's chance in hell a child is going to tolerate that. I mean, that's not on, which is why he's wearing it. But it's really uncomfortable, you know, and compliance with CPAP in adults is really rubbish. It's really unrealistic to expect a child to tolerate CPAP. And the reason I say that is because sometimes parents come in and they'll say, I don't want surgery, I'd like my child to have CPAP. Because, understandably, it doesn't involve general anaesthetic and surgery. But nearly, this year I'll be 24 years doing this job, and there's no child outside of baby infants that don't have the coordination to do this that tolerates CPAP. It's very uncomfortable. It is very uncomfortable. So this is nasal CPAP, where the mask is just here. But if your child has a small jaw, it's nearly always going to be a full face mask CPAP. So it's even more claustrophobic than that. Yeah. So wafting oxygen, CPAP, and then taking the tonsils and adenoids out. And then lastly, I wanted to speak to you about hearing loss and language, and that's in the context of apraxia. So apraxia, very little, so I spoke to our speech and language therapists, and they had very little experience with apraxia, and that's in the biggest tertiary children's hospital in Europe. But I didn't want just to focus on apraxia, because children who've got GAND are children who happen to have GAND, and children all share common things. And it's that bit that I wanted to, because it's, the obvious thing to focus on is that apraxia, but there's lots of other common things that children can get, far more common than apraxia, that you need to address before you start addressing the apraxia. So, my slides are the wrong way around. Medically, when we talk about the ear, there are 3 parts to an ear. So you've got the outer ear, which is this bit that you can wiggle and stick your finger down. That stops here at the eardrum, and this is the middle ear. Normally it's full of air. You've got 3 little bones of hearing, and it connects via this tube called the eustachian tube to the back of the nose. Can you see? Yeah. This bit here that looks a bit like a snail, that's your inner ear, and that's encased behind bone. And if your child passed their newborn hearing assessment, there's about a 93% chance that there's nothing wrong with that part of the ear. The commonest bit that doesn't work in children is this middle ear bit. And the reason for that is because of that tube, that eustachian tube. In children, because it's controlled by a muscle, and we've already discussed that hypotonia causes issues with muscles, the opening and closing of that tube is under the control of a muscle. So if you've got hypotonia, that muscle doesn't open and close properly. So you know when you're going up and down on a plane, your ears pop, it's that tube, and that's what it's trying to do. If that tube doesn't work properly, the pressure in that middle ear is lower than the pressure behind, well, it's lower than the pressure in the nose. And effectively, what that low pressure does is it means the lining of your ear starts to release a really thick, sticky substance. And that's where the phrase glue ear comes from. So the problem isn't primarily with the ear, the problem is with that eustachian tube, yeah? And then if I go back to that picture, can you see in the adult, that tube sits at an angle. So even if you and I did develop glue ear, it nearly certainly drains off. But in children, that tube is flat. So it just tends to stay there. The other functional implication of that tube being flat is that in children, all their infections, nearly all their infections, are ear, nose, and throat infections here. So that can reflux back up into the ear. So the pattern is nearly always they had cough or cold, they get better from that, and about a day or two later, the ear kicks off. But that makes sense because that's the way we're engineered. Yeah? So, yes. The reason why glue ear is important is because it's fluctuating. So it can come and go like this. But it will impact your child's hearing, their listening, their language development, their behavior, and their emotional and social well-being. Yeah? And all of those things based on the literature and the fact that we're all human makes sense. Because if you can't hear at a dinner table, if you're at a dinner and you can hear but you're at the end of the table and you're not part of the conversation, you tune out after a while. And that's what nursery people will say. You know, in nursery, the child just seems to be in their own world, they play by themselves, and that's really sad. Because actually those things are far easier to fix than the apraxia that I think people will be focusing on. This is a healthy eardrum, and you can see that sort of light reflex, it's this kind of pinky grey. That's glue ear, and you can see the kind of bubbles within the fluid behind the eardrum. It's a bit like if I said to you, stick your head under the swimming pool, and I speak to you from the surface. You can hear, but you hear half. And it's usually the lower frequencies of sound. So if, for example, you said fish, your child might say bish. So close but not quite there. Yeah? And so, you know, the kind of things that parents will pick up on or that nurseries will pick up on is that they mishear. So they have words, but they're not entirely correct. One or two alphabets are off. They'll have difficulty in a group. So one-on-one, when they're speaking to you at home and it's quiet, they're generally better. But in school, I mean, school's like a zoo, right? I mean, nursery in particular. When lots of people are speaking at the same time, that's when they struggle. But that's where they spend their time. And they tend to ask for things to be repeated. The volume on the radio and the TV tends to be up. And those things, I'm sure, are far more common in your children than apraxia. But they will feed into that apraxia. But these are the key things to kind of focus on. So it can cause all of these things, behavioural issues, lack of concentration, attention. Because if your child can't hear in a classroom, why would they listen? They just tune out. Because they can't hear to get involved. Poor educational progress, balance difficulties. Because of course, aside from hearing, your ears do balance. Yeah. These, I mean, you can screenshot this. These are the guidelines for how in the NHS we should manage children with glue ear. And you should screenshot them because lots of community audiology teams don't follow these guidelines when they should. So they keep checking the hearing test again and again and again and again. And actually, the guidelines are 3 months. If your child has glue ear over the space of 3 months, we need to do something. Whether that's hearing aids, whether that's grommets, we need to do something. But not infrequently, people are just brought back again and again, years sometimes, with glue ear. But the guidelines are clear, 3 months. And then they get referred for an ENT assessment. And these are the NICE guidelines. The NICE stands for National Institute of Clinical Excellence, so they're national guidelines. So the assessment is a hearing test, and we reassess that in 3 months. The reason for the 3 months is because it takes a normal ear, anyone's ear, 3 months to clear glue. That's a long time. But that's why we don't intervene before 3 months, is because it's entirely normal for an ear to take 3 months to clear glue. If there's glue in both ears, then we reassess after 3 months. If there's glue in one ear, you consider reassessment of hearing after 3 months. In children who have any sort of developmental issues, we should be retesting, because they're more vulnerable to the effects of that hearing loss. And this is the key. The guidelines were modified. So you can see they were modified in 2023, post-COVID. The reason is because there's an increasing recognition that in any child where it's affecting their day-to-day living, the healthcare system, the NHS, is so beleaguered at the moment that usually by the time you have your audiology assessment, your child's already not been hearing for 3 months. And so waiting that 3 months again is just daft, because it's punishing the child for a system that doesn't work. So increasingly, this whole thing is joint decision making, right? So we know the medicine, but you know your child. So if you come in and you say, my child hasn't been hearing and I've been worried for a year, and that hearing assessment is bad, we should consider doing something rather than waiting 3 months. And these are the 3 somethings that you can do. You have bone conduction hearing aids, air conduction hearing aids, and grommets, and they all do different things. So a bone conduction hearing aid looks like this. It's a soft band. Some of your children may already have it. It slips on, it slips off. It's like a hairband. Yeah? It's useful when the hearing levels fluctuate, or when there's some reason why your child can't have in-the-ear hearing aids, like very narrow ear canals, or if they've got eczema in their ears and the hearing aid irritates the skin of the ears. A hearing aid will help with hearing loss, but it won't do anything for ear infections. So it depends on your child. If the problem is hearing loss and ear infections, probably not the best option to go for, but useful for fluctuating hearing loss. An air conduction hearing aid is this conventional hearing aid. We never give children in-the-ear hearing aids. We never do, because they're tiny and they will get lost. They're really small and they're see-through. So they always have behind-the-ear hearing aids. So this is useful when the hearing loss doesn't fluctuate, so it's where it's pretty much fixed at a certain level. And it's for children who have sensory issues that don't like the band around their head. So again, it'll help with hearing loss, but not recurrent ear infections. And then the last option then is grommets. And the thing with grommets is they're tiny, so that's a fingernail and that's a grommet. They're really, really small. So you can see it's shaped a bit like an old-fashioned bobbin that you'd wind thread around. Yeah. To put a grommet in, a child needs to have a general anaesthetic. Actually, you could have a grommet in under local anaesthetic because you'd hold still. But in a child, that's not an option. So that's the reason for a general anaesthetic in a child. So in a clinic, as I said, in the past life, I did adult head and neck cancer surgery. After chemo, they'd get glue ear, adults, and you could bring them into clinic, give them a local anaesthetic, put the grommet in, and they drive themselves home. It's not a painful procedure, it's really fast. But a child won't sit still, so that's why the general anaesthetic. Day case, it lasts between 6 and 12 months, in and around that sort of time. This is a key in children. It doesn't depend on compliance. It doesn't depend on your goodwill about whether or not they're going to wear it. It's there. Yeah? And it will help with both hearing loss and recurrent ear infections. So to put a grommet in, you make a little nick in the eardrum, and you put the grommet in such that half of the grommet sits, well, so it straddles the eardrum, basically. Yeah? And people think the purpose of the grommet is to let glue in. It's not, it's to let the glue out. That's not the purpose of the grommet. The purpose of the grommet is to let air in. So for the time that the grommet is in, it does the job of that tube. It ventilates that ear. Yeah? So the risks of the grommet are small risk of general anaesthetic. It's incredibly rare for a child to have a problem with the general anaesthetic outside of a family history of issues with general anaesthesia. Really rare. The reason is because the medicines that we use to put a child to sleep have been tested on thousands and thousands of children. Equally, if you were to have a reaction to a medicine, there's probably not a safer place you could be than the operating list of a hospital, because literally everything that you need is on hand. But in 23 years, touch wood, it's never happened to me. Yeah. Ear discharge. So at the end of the day, a grommet's a foreign body, and it's got no business being in the body. And so sometimes the ear will discharge. So there's a 1% risk of kind of what we call otorrhea, ear discharge, and that can be transient or ongoing. In about 24 years of doing this, I can count on one hand the number of times we've had to take a grommet out because it was causing that much trouble, but it does happen. Risk is not zero. When a grommet falls out, there's a 1 in 100 chance you're left with a perforation. And if the child had a perforation, then it would need further surgery to fix it. And that surgery would be more extensive than the grommet. It would be harvesting a bit of tissue from either behind the ear or cartilage from here and using it to patch the eardrum, scaffold the eardrum. And then there's a risk that the grommet can fall out early. Yeah. And I think that's the end of what I had to say from an ENT perspective. In terms of the neurodisability practice that I have in the Children's Hospital, what I have learned is perfection is the enemy of good. Children, like all of us, they evolve, we evolve. So the child that you have in 2025 might be different than the child that you have in 2026. So do what you need to do to get the child good enough for now, and then hold, and then wait and see what more you need to be doing. Take the easy wins. So if your child has multi-level airway obstruction, including big tonsils and adenoids, take the tonsils and adenoids out, and then see if the child is good enough. Think holistically, and then think multidisciplinary. So it's all these specialties coming together to look after these children. So in the Children's Hospital, we have a neurodisability MDT where we've got neurology, a paediatrician, pediatric respiratory medicine, and pediatric ENT. And that works very well for our children. And thank you for your time.
Are you happy to take any questions?
Yeah, gosh, yeah.
Any questions for Dr. Mira?
With glue year, a non-GAND child has glue year, the last few years, they won't do anything about it. They basically said that I put the referral in, by the time she's seen by ENT, they confirm she's got glue year, but it's not severe enough to have vomits or a urinate. Literally, she grew up to it. Is there a point that she will, or?
How old is your child?
She'll be 8 in June.
8?
Yeah, she'll be 8.
She should have long grown out of it by now.
Yeah, and she's at the moment she's got urine loss in one of the ears. So.
Does it impact her, do you think, as a mum?
Sorry?
Does it impact her?
Sometimes, but she's really clever and she plays on it as well. She plays for advantage over a few years. So.
Big buggers, aren't they? I think
she has been under the ENT because she was assessed for sleep apnea as well. Because she has got enlarged tonsils. And it's really bizarre. We basically said, yes, she stops breathing on average twice an hour, but we won't do nothing about it.
was that on the basis of that oximetry? Yeah, I mean, those studies are absolutely rubbish. Snoring, mouth breathing, breath holding, restless sleep. Is she tired when you wake her up in the morning?
Yeah, she can be when she is.
Does she move around a lot when she's sleeping?
Yeah.
I mean, it's a problem, because I think we've fallen into a habit of using those tests to reassure people.
Yeah.
But it's a really poor yield study. So if she has all of those signs and symptoms, and she's got big tonsils, she probably would benefit from having her tonsils out.
Yeah, he said he wasn't going to remove them because she does suffer from tonsillitis.
She does suffer from tonsillitis.
The last 18 months, I think she's had it like once.
Okay, so that's good.
It's necessary to do that.
But there are two separate indications, aren't they? So tonsillitis, the kind of guidelines are 7 episodes in a year for 1 year, 5 a year for 2 years, and 3 a year for 3 consecutive years. But the indication for this is different. It's not infection, it's obstruction. It's sleep disturbance. So I think if she had all of those symptoms, it's worth considering. And if she had glue ear at 8, she should have grown out of it. So the guidelines, those nice guidelines say, if the hearing threshold in the better hearing ear, because they're rarely ever equal, because we're not mirror halves of each other.
I think one of her is more lost than the other.
Yeah. So if the better ear has hearing thresholds of 25 decibels or worse, then yeah, she is a candidate for.
They just like discharged us and basically said, you know, if you get any more, refer back in. So
Yeah, and that's why I put those guidelines up. It's probably worth going and taking those guidelines back to them to say, you want these guidelines. I think the problem is our waiting lists are, so in the children's hospital, it's 52 weeks for us to see a child, and then 52 weeks for surgery. And the problem is, it's probably not the doctor that's made that decision. It's probably an administrator along the way, which is why I think it's worth taking those guidelines and going back to say, yeah.
But she shouldn't be negative by her age now.
Yeah. I mean, eight is plenty of time. So glue year kind of peaks at about 2 or 3, and then there's a second peak at about 5 or 6. But by 8, no. And nearly always, if she was going to grow out of her sleep disorder, she would have done it by now. So it's interesting. In pre-COVID, we had a load of children who were waiting for tonsils and ads, but of course we stopped operating because of COVID. And then when we started picking up again, we'd ring to see how the children were, whether they wanted to do it for surgery. About 60% of children had grown out of it, in that 1 year. But that's because the commonest age for tonsils and ads is about 3, 4. It's in and around that sort of age. So we're kind of born with adult-sized tonsils and a baby-sized head. And if you look again in a year, tonsils that looked massive when they were 3 sort of look much less massive when they're 4. It's not that the tonsils are smaller, it's that their head is proportionally bigger, so the degree of obstruction is less. But by 8, if she still has those symptoms, then take those nice guidelines with you, though.
And speaking of that, because I know we're welcoming guests from overseas here, all of this is being recorded and will be provided to you, so if you do need to go back and address any of the information, and maybe with your blessing, I'll speak to Rebecca, some of these slides we might be able to make available.
Yes, of course.
So that's great news. So you can get this whole presentation again, because I understand it's very, very difficult. English isn't my first language either, like my Welsh friends.